Today we have with us Dr. Mathis one more time. Dr. Mathis, you and I have made several videos and they have been so incredibly helpful to so many women. And you came into my life when I was really struggling, and I had seen several different physicians, spent tens of thousands of dollars, didn't get any help, was told there's something wrong with me, it's normal to feel this way. And then you came into my life. And then you came into my life and you literally saved my life. And I know you're quite humble and you don't like to toot your own horn, but I have not met many physicians who are so passionate, really trying to understand their patients and trying to help them. So my first question I have to you is, what motivates you?
So I practiced medicine for urgent care for 13 years. And I noticed that nobody got better, that no matter how many pills they were on, they actually got worse. So I got tired of handing out pills. And I decided I wanted to look into the reason why people were sick instead of just giving them a pill for a symptom. And this is what the alternative integrative holistic physician is all about, is trying to go to the source of the problem and fix it. I mean, actually fix it. I have an extreme passion to try to figure out why things don't work the way they're supposed to, and then try to apply a solution to fix it. I've attended over 7,000 hours of lectures trying to seek out these answers. How does the system work? What's the pathophysiology? The answer is, for the women, it's simple. You know, you give them the hormones, and I have women call every day and tell me how their life is, they have their life back. And this is fixing something that's seriously broken. And they get their relationship back, they get their life back, they get their kids back. I don't know how women can live without the hormones. Some are okay. There's a few, probably 5 or 6%, 7%. But most women are just disabled without help. And then I'm a caregiver. There's different kinds of personalities, and I happen to be more like a caregiver. So I'm willing to take the phone calls, and I learn a lot. When people call, you learn so much. Like today, I had a person start her hormones. This was her first day, and I've never had anybody call me up and tell me they didn't feel good putting on the hormones. This is the first person in 15 years. What's going on with her?
But see, this is what makes you so special. You actually wonder what's going on with her. You don't just, I was told there's something wrong with you. It's you. You know, when I met you, you sat down with me. We sat down for a couple of hours and you listened. You didn't just look at my labs. You didn't just treat the labs. You listened to me. I don't think I've ever felt that understood. And like I said, you saved my life. So one question I get quite a bit, because I had seen these other physicians and I was put on different kinds of hormone replacement therapy. What you did, the hormone replacement therapy you gave me, what was different about that?
Okay. Well, probably the combination of how they're made and the ingredients, you know, the crystal size. The estrogen crystal size is important. It has to be small enough to be absorbed into the cream so they can pass through the skin. And that's going to depend on whoever is making the hormones. So there are courses that the pharmacies can go to and learn how to mix these things. And it is a bit of a science. It's not rocket science, but it's getting close. And so you have to have the right base cream for the right person, and then the right crystal size, which is pretty much, that should be normal. It shouldn't be a problem there. And then it's trial and error, and you just try these things, and I have a number of success, 90, 80% success, no problem. And then you've got that 15 or 20% that it's tough for them. It doesn't absorb. I have maybe one person that's on oral hormones because there's just no way it's going to go through her skin. I don't know. Her skin is just so dense that it just can't pass through it. Yes, it's a science, and you have to mix it all. And the most important part of this whole thing is what you said, was communication. Please call. Please text or call. If you don't feel good, I need to know, because the whole point is you're supposed to feel better, not worse. And so communicate. You've got to talk to your doctor. If you have a provider who won't get on the phone with you or won't text you back or email you back, then you need to find one that will, because it takes two people. It wasn't just me, Claudia. It was you working on it based on what you told me. I would tell you to do this. And then you tell me, I'd say, do this. And then we would just, finally, we got it right. And that's how it
Yeah.
works.
But that can happen. It can be some trial and error. I think a lot of women expect to see a doctor, be put on hormone replacement therapy, and then everything is great. And that often doesn't happen because everybody is different. Something might work for my best friend, but not for me, or the other way around.
I've had that happen. One person called me and said, my friend's taking this. Can we try this? She didn't do well on it at all.
You told me one time that hormones are like a lock, or the receptors are like a lock, and the hormones are like the key. And the key has to fit the lock, and everybody needs a different key. And that made a lot of sense to me because, like I said, I tried 6 different forms of hormone replacement therapy, and none of them did anything. Every time we measured my blood, my estrogen was still non-existent, my progesterone was non-existent. And then I saw you and was like, whoa, within a month I felt good again.
We got it to work. Yeah. I have a woman in Texas like that too. Her numbers were low and we couldn't quite get them. And all of a sudden that we got the right combination and now her numbers are great.
I think that's very important for women to know that if you've tried something and you still don't feel good, first of all, don't give up. It might be that you need more. It might be that you need something different. But like you said, communication with your provider is so important.
Got to talk to your provider. The only way is to communicate with your provider, and you have to have one willing to do that, to make all these little adjustments. And you can't charge for every second you're on the phone. That's not going to work. You've got to be there for them.
You won't believe how many women tell me, my provider put me on hormone replacement therapy. They didn't test me before. They're not testing me now. I'm still not feeling good. They're refusing to test me. They're refusing to give me something else. What do you tell these women?
New provider.
Yeah, and sometimes another one and another one. I know for me, it took 2 years until I found you. And in those 2 years, I don't want to sound dramatic, but I was just about wanting to jump off a cliff because I just was hopeless. And I get emails from women like that almost daily telling me that they are hopeless and that they just aren't enjoying life anymore.
They can, depending on where they live, they can go to the health food store and you can find some estrogen and some progesterone, or estriol and progesterone, in the health food store. And you can give yourself something instead of nothing until you can find that doctor you want to work with. And then anybody can always fly to California and see me, or if they're on a vacation, they can come over here. And then that's once I've seen them, then that's it. Then they can be a patient anywhere in the world, or on Mars if they want to.
Now, I have talked about this before. I use a rhythmic hormone replacement therapy. Let's talk about that really briefly. What does that mean, rhythmic hormone replacement, and why is that a form you prefer?
The body operates in rhythms. Just about every system has a rhythm, a rhythmic flow. The adrenals come up in the morning and they go back down. And then before lunch, they come back up and they go back down. They come back up at 4 o'clock. So everything's in rhythms. So women have a rhythm. Men have a rhythm. They just don't have the same rhythm. No. Comedy, sorry. Okay. So the answer is women's hormones are best given in a rhythmic fashion because there are a number of physiologic processes that occur at each particular point in the system. When the estrogen is peaking, that's a particular point in time. When estrogen falls on day 13, 14, that stimulates an LH surge, which then helps you with progesterone reception. So there's a lot of physiologic mechanisms that are in play. There's something called P53 that's turned on, which goes out and cleans up defective cells, cancer cells, different kinds. Anybody who's not doing their job right, that system goes out and gets them and cleans them up. So when you use a rhythm, you are obeying the genes. When we obey the genes, we stay out of trouble, a lot more likely to stay out of trouble than if we don't obey the genes. They only know one thing. For women, it's this. And we're not supposed to live past 40. At the turn of the century, people were dying in their 30s. We live now to be very old. Yeah. I can testify.
But our hormonal system hasn't caught up.
When women are out of the reproductive range, Mother Nature says, oh, you can't produce children? Okay, we're going to check you out of the hotel. You can leave now. I said,
Yeah.
what? I don't want to leave. I've got grandkids. I've got all these. No, I'm not ready to go. So the answer is we have to do something to help with their health if they're going to stay longer. So that's where the rhythmic hormones. I have people on rhythmic hormones up as high as in their 80s. I mean, okay, the doses are small, but they still have a rhythm. The rhythm also helps with bone density. I've seen the bone densities go from terrible back to normal. Takes about 2 years if you put them on rhythmic hormones. And the rhythm is the brain, the vascular tree, the heart. There's almost no tissue that doesn't benefit from rhythm of the hormones. Okay. So I'm trying to put a book together on estrogen. Hopefully that'll be out in a few more months. And it's just going to answer these questions like, what's the big deal with estrogen? And the answer is, just talk to Lizette and she'll tell you. Because she was 3 years old when she got radiated with chemo and radiation for her cancer. It killed the ovaries. She walked in the office at 23 years of age with no hormones ever for 23 years. She had menopause on top of menopause. She got D's and F's in school. She couldn't sleep. All the different pills they gave her didn't work. This is the book. This is what the book is based on, is Lizette's story. And
This is a patient of yours.
She's a patient, and I have permission to talk about her. She's going to write her companion book so she can explain to people, oh my God, you won't believe how she felt. She's going to put it down in writing. This is how bad it was all this time until she got on rhythmic hormones. And static dose is okay if a person just doesn't want to have a cycle, doesn't want to have a period. You can do static dose. Hormones are better than no hormones.
Let's back up a second just so people understand what that means, rhythmic dose. So I'm on a rhythmic dose. That means that my estrogen goes up and then
goes up on
down.
Day 12, comes down.
Exactly. And then my progesterone
goes up on Day 21, comes down. Yeah.
So I don't always take the same amount. The amount I apply on my skin, I take a bioidentical cream. It varies. And static, you take sort of like a birth control pill. You take the same amount of hormones all the way through.
Right. Progesterone every night. Because if you don't take that progesterone every day, every night, then you will have a cycle at the end of the month.
And some women find that to be a disadvantage of rhythmic hormone replacement therapy, is that they have a cycle. I personally love it. It makes me feel that my body is just doing what it's supposed to do. But like you said, if somebody doesn't want that, then they can go on a static dose.
And they go on a static dose. And it's not in harmony with the genes, but this is this is a choice, and they feel much better with hormones than without hormones. We don't get the same activity with P53 and other mechanisms as we would with the rhythmic method. So it's because we're copying nature. And if we copy nature in general, we're doing the right thing. So.
But would you say static hormone replacement therapy is better than none?
I would say it's better than none, because without hormones at all, people just feel terrible. And the brain doesn't work. They have brain fog. A lot of times they don't sleep because there's an enzyme that controls serotonin. And that enzyme is controlled by estradiol. So if you have your estrogen in place, it blocks that enzyme from breaking down serotonin, which means that you keep your serotonin level up, and that helps with depression. So this is one of the common problems with women in menopause, is they get depressed because they're not holding their serotonin up with the estrogen. So that's a static dose will do that for you.
Okay. So static dose will keep the serotonin up.
Static dose will keep you going, and you can't have, if somebody doesn't want to have a cycle, then that's what you have to do. There's no other choice. You have to do that. If they have a hysterectomy, then there's no cycle. I have a lot of women like that they've had a hysterectomy for whatever reason. Now the perfect chance to put them on a rhythmic program, because there won't be any bleeding. Okay. Now Lizette, she's a classic example. She developed some kind of a thing in her pelvic area, so they just did a hysterectomy on her. They took out this mass. It was benign, but they took it out, and now she's not going to have periods anymore. Okay. She was having cycles for the last 10 years. She won't have cycles because the doctor wouldn't leave the uterus in because they don't think it has any meaning. But the answer is it does.
How old is
She's
Lisette now?
31.
Very young.
So
Okay.
she's going to continue the rhythmic method, but we just won't have the marker because now we don't have that bleeding that tells us that we got the rhythm right.
Mm-hmm.
Okay.
One question I get quite frequently is, what does bioidentical mean? Really briefly, tell us what bioidentical actually means.
So bioidentical means that the molecule has the hydrogen atoms in the right place, carbon atoms in the right place. It's an exact replica of the molecule that you make yourself. So that's a bioidentical molecule. There are non-bioidentical or synthetic molecules out there. Synthetic estrogens, synthetic progestins, those are dangerous. We don't use those. And the hydrogens are moved, the carbons are moved. They don't look the same. They're not the same molecule, and they create a different action on the cell. So I use bioidentical. I only use bioidentical, and especially avoiding the progestins. They call them progestins, the synthetic progesterone.
Okay.
So exactly the same one you make. That's the bioidentical. Okay.
So again, keeping nature happy. We are mimicking a cycle, and we are giving the body what it recognizes.
Yeah. It's a massive system with so many enzymes, thousands and thousands of body reactions per second going on. It's far better to use bioidentical molecules. Body knows what to do with it.
Mm-hmm.
What do we do with this? You know what to do with that. It's the same molecule you make.
Mm-hmm. There is, of course, always the fear of, and this is something I hear a lot from women as well, but it's going to cause cancer. To my knowledge, there has not been one study on bioidentical hormones actually proving that they cause cancer, correct?
Correct. There's a group here in California that has just gotten an IRB, an Investigational Review Board approval. Mm-hmm. And they are going to have a control group and a hormone group, and they're going to use rhythmic hormones in the non-control group, and they're going to start this study. It's going to last 3 or 4 years, and we're going to see what happens. So we're actually going to have a real study. Number 2, if hormones caused cancer, pregnant women would be dying. I mean, your estrogen level, I had one woman come in and she said, well, I didn't have a cycle. I said, okay, well, let's check your hormone levels. So I checked her estrogen level. It was 3,200.
Wow.
I said, guess what? You're pregnant. She said, what? No. I said, yes, you are. And she had a beautiful little girl. So the answer is 3,200. All I'm trying to get to is about 125, 175, somewhere in there. That's enough for hormone replacement. This was 3,000. So pregnant women have a progesterone of 50, and they have an estrogen of 3,000, and they're not dying. Mother Nature's not going to let that happen because somebody has to feed that little guy or person.
And you also told me you have a colleague who is a breast cancer doctor, and she has done.
Oh, Dr. Taguchi, yeah.
Yeah.
She has about 175 patients now, and that she has in this study of her own. And the women who have had breast cancer and went back on hormones have fewer recurrences of cancer than the women who don't go back on hormones. Mm-hmm. Mother Nature doesn't want women to have cancer because they're supposed to be having offspring, not cancer. They're supposed to be having children. It is in the literature that if you have more than 5 pregnancies, the chance of breast cancer is about 0.
So where do you think this fear of cancer and hormone replacement therapy comes from? Because it is something that keeps getting repeated and repeated, and women talk to me about it all the time. Where does it come from?
All right. So in 2001, they had a large study, women's study, about 50,000 women, and they misreported the study. They had 3 wings as a study. They had one with synthetic estrogen and synthetic progestins. Mm-hmm. They had a control group, and then they had a synthetic estrogen only group, no progesterone.
Okay.
So the results were only reported for the synthetic estrogen and synthetic progestin group. And they said, oh yeah, these people have more cancer. All right. Turns out that's the progestins. Mm-hmm. What the media failed to report was that the synthetic estrogen group that had no progesterone or progestins, the synthetic estrogen group only, they had fewer cancers than the control group. Oh, what does that mean? In other words, people who took no hormones at all had a greater risk of cancer than the people who took hormones. Even if it was synthetic estrogen, it still prevented cancers from happening. In fact, this whole thing is, in my world, from the courses I've been to, cancer is an inflammatory disease. You have to be inflamed, and it starts out with a little inflammation, a little more, a little more, a little more, and then finally the cells break into cancer because they lose control. They become so agitated and irritated. I mean, they're little people, these cells that we live with.
And estrogen is actually anti-inflammatory, right?
Estrogen, anti-inflammatory. It's anti-diabetes. It's anti-inflammatory. I mean, I've kept A1Cs down with estrogen from diabetes. So it's the inflammation that is the problem. We have the chemical and toxic insults that create inflammation in anybody, men and women. But in the case of the breast tissue, very sensitive to toxins and chemicals. Mold can be also a factor in terms of toxicity. Okay, and then the radiation that we have, the Wi-Fi's, and so forth.
But it is not estrogen that causes cancer. Again, there has not been a study saying that bioidentical hormones, or as you mentioned, even synthetic estrogens, cause cancer.
So here's this little story I tell. I've had 3 cases of cancer in 14 years with women putting on hormones. This is my take on it. When you put the estrogen on, if breast cancer is a 15-year to 20-year disease. When you talk to the people, you look in the literature, they say, oh no, it takes 15 years to get this going. And you don't even see it for the first 7 years. You don't even notice anything's going on. And then finally, at the 10-year mark, you might see some little lumps or whatever. So the answer is it's a long-term disease. That's inflammation. It takes a long time for that to cause a problem. Okay. So you put the hormones on, and if there's anything brewing in the tissue, it's going to pop its head right up. I've had that happen 3 times. I went to the cancer gurus who do the treatments and so forth, and I said, what do you think about estrogen being an early warning system? They said, what are you talking about? Early warning? I said, yeah, early warning. You put this on, if nothing happens in 6 months, then the answer is there's nothing there. There wasn't anything there. There's nothing. You're clear. That's it. And that's what seems to have happened with the rest of these people I have, all these other patients. So in my world, it's like estrogen is a lifesaver for a lot of reasons, including it's an early warning system. If there's some crazy little thing going on, it's going to show up because those tissues are estrogen sensitive and progesterone sensitive because they are. Those are female tissues. And they respond to the hormone. Of course they do. Okay. And if they don't, you're in huge trouble. If you have a cancer that doesn't have receptors on it, it grows crazy and there's no way to control it. Whereas if you just take away the hormone, the cancer stops growing. Like in men with prostate cancer, you just take away their testosterone, which they get so sick without testosterone, just like women without hormones. Men get so sick without their testosterone. I have one right now. He's suffering horribly from his hormone therapy to try to get rid of the testosterone.
And that is often the treatment for women. If there's breast cancer, they will block all the estrogen. And I've seen friends of mine suffer horribly.
It's just menopause on steroids when they block all the estrogen. There's nothing. Or women have surgical menopause because they take out the ovaries and then they end up on some kind of therapy like that. They have 0 times 0 estrogen, and they really don't do. You have to have these hormones. The argument is there isn't any. It's you need to have hormones or you don't have quality of life.
Yeah. Good. This is a question I get quite frequently. What is a good estrogen number to shoot for when you're on hormone replacement therapy? Now, let's say when you're on Rhythmic, because they're going to change, and then we can talk about static.
So on a static program, I like to see them. Typically, if you want to have a physiologic effect, you need to be above 100. Otherwise, it's just not high enough to create a feeling of good, a feeling of wellness. When you put on a Rhythmic program, then the background level is probably going to be about 125 to 150. And then there might be a peak that goes up over 200 on day 12. And progesterone is the same. The progesterone will be, the background level is probably around 0.5 to 1.0, 1.5. And then the peak will be anywhere from 2 to 6, 8, 10 on up. Depends on how well the person receives the hormones.
What about static progesterone if you're on a static?
So I don't like progesterone to be too high. So when I see, for example, I have women who are taking 100 milligrams of progesterone and their level is 15, I'm going, that's way too much progesterone. And I'm surprised you're not depressed, weepy, unhappy, sad, fatigued, can't get out of bed. I mean, that's a lot of progesterone, and it really knocks people out. And some people lose that they can't think right because it's basically canceling the estrogen. So that much progesterone. So I like to see it somewhere around 2 to 5, depending on the estrogen level. It should be about 20 times more than the estrogen, because one is nanograms and one is picograms.
Oh, okay.
So basically, they want it to be 20 times more.
Okay.
And that's the normal rhythm. That's the normal. On day 21, the progesterone could be anywhere from 15 to 19. I've seen those people pull those numbers themselves that have good hormones, and their estrogen will be like a 200. So if you do the math, you can just divide 15,000 by 235, and you can figure out what the ratio is. And that's how you do that.
Okay, that's good to know because I get that question a lot. Now, what is definitely way too low? I know when I wasn't feeling good, my estrogen was about 40, and that I felt horrible. What is way too low?
Well, the menopause range is anywhere from probably 40 to 56, depending on what reference range you're looking at. Typically, when people are less than 70, they don't usually feel very good. They'll complain, and I'll say, well, let's get a number. And then we get the number, and here it is. It's like 55 or 60 or 70. You know, well, no wonder you don't feel good. You don't have enough estrogen.
Let's talk about that really briefly, because you said the menopausal range for estrogen. So if I'm 53, if I go to the doctor and I say I want my estrogen measured and it is in that menopausal range, they're going to say to me, you're normal. This is what you're supposed to feel like. Yeah, exactly.
You're perfect. Yeah, peace, happiness, go home.
But you obviously don't want to be in that menopausal range because that's when you feel horrible. Yeah.
No. Yeah, the women feel terrible. They tell me this. They go and say, well, yeah, my doctor says I'm perfect. I got a 43. He says, thumbs up, you're good. And it's just like, oh my God, what's wrong with these folks, man?
To feel good, you don't obviously want to be in the postmenopausal range.
It's amazing how low the hormones can be and be considered normal. I've seen women that have cycles. They're still having cycles with their numbers in the 70, the estrogens in the 70. I just can't believe it. But Mother Nature, okay, one more time. Okay, one more time. One more. It just keeps trying to do this because it's programmed. There's no escape. This is what the program is. You can't change that without changing the genes.
Yeah. What would you say to women when they first go on hormone replacement therapy? Because as I mentioned earlier, I have women tell me all the time, my doctor didn't test my hormones before they put me on something. They're not testing them now. What would you say? First of all, of course, you have to test them before you put them on something. But how often then should they measure their hormones just to know that they're doing the right thing?
So in general, I always like to get a baseline. I want to know where people are. Okay. So we'll get a baseline. That's the first test. And the second test would be anywhere from, depending on the person, I would say during the first month or the second month at the latest, I'd like to get a hormone level and see where we are. Okay. If there's any doubt about what's going on, I just say, get a level. Let's just get a level. And you can go to Life Extension here in the US and you can order for $56, you can order all the hormones. You got to test until you know that they're steady. And then once you've got them going, test them once or twice a year is enough. Okay. But then the first few months, you're going to test a few times to see where we are. And you just have to have resources to do that. Yeah. Some people just literally don't have enough money to do this program. And there's a recurring cost with the hormones that it's not much less than $40 per hormone. Yeah, it's not cheap. It's pricey. Yeah, so that's $80. We'll call it $100 a month right there, just to buy the hormones. I mean, I'm the cheapest part of the whole program.
You are. That is something that I
Yeah.
think needs to be taken in consideration as well. It is not cheap. Bioidentical hormones are often not covered by insurance.
Some of the pharmacies aren't very good at it.
Mm-hmm.
Okay, they're not as good at making them as other pharmacists. So if one isn't right, you've got to, move. I've got to go where I know they're going to make them right. And
Yeah.
they are complicated. They are hard to make. So that's another issue that's part of the treatment plan is the doctor, the patient, and the pharmacy that makes them.
Mm-hmm.
And all those dots have to be connected and work. And that's where that communication is. Not right. You got to reorder, get them to change the base cream.
I think that's something important for women to know, that it can be quite complicated. It's not as simple as I don't feel good, I go to the doctor, he gives me something and I feel fine. It can be quite a journey, but it is a very well worth journey because you only live once. And if you don't have that quality of life you want, then what's the point?
Right.
Now, one question I get quite frequently also is, we know that women in menopause can gain weight, but I have a lot of women being very afraid if they go on hormones, they will gain weight. What do you think about that?
So the answer is, from what I've seen, estrogen is an anorectic. So basically, it should stop them from eating, which is interesting. Progesterone is not that way, but estrogen is. So in theory, people eat less when they're on the hormones. But it seems like what happens with estradiol and progesterone is there's about a 2-pound water weight gain because it tends to hold fluids and it holds moisture more, so that the wrinkles on the face and stuff they're gone. It holds that little bit of fluid, and that seems to be part of the hormone program. So that's a couple of pounds. And that's I've had some worst case where people gain more weight, but I'm not sure if they just didn't feel so good. They went out and ate a bunch of food. I mean, I don't know. I don't know what happened.
But estrogen also helps you put on muscle, which is metabolically active. So, your metabolism will speed up. So really, in the long run, it really should not make you gain weight, but actually the opposite. Because without estrogen, we lose our metabolically active muscle and our metabolism slows
and
down. And
testosterone also helps with muscle. Yeah. So both estrogen and testosterone help with muscle, and that produces a high metabolic rate tissue, which keeps the weight down. Muscle is much more active than fat tissue.
So since we're talking about testosterone, how important do you think testosterone is when a woman is on hormone replacement therapy?
We just want to be careful with testosterone. Lately, I've seen some pretty high levels. Some of the women are they're using injections for testosterone. One person's level was like 380. That's more than a lot of the men I see. So, I mean, that's too much. Yeah. And that much testosterone, you can get hair loss, you can get acne, you can become very aggressive, very hostile. Some people get that way, and not everybody, but some people do. And then it blocks estrogen. So you're really not going to, because it shares a receptor. So if too much testosterone just overwhelms the estrogen receptor, and now you have a negative effect. You're better off pull that testosterone down and get that estrogen kind of where it needs to be. And the magic number is not the total testosterone, it's the free testosterone. So what you're looking for is a total and a free that are somewhere in the range.
Okay. Now, I've had a couple of women tell me that they have pellets and their testosterone went skyrocketing high. Is that something you've seen with pellets?
Oh, yeah, that happens.
Yeah.
And you can't take the pellets out. So now you got to wait 3 to 6 months for the levels to come down. And in the meantime, you're under the high anabolic effects of that huge level of testosterone.
So your preferred hormone replacement therapy is definitely Bioidentical Rhythmic with a
Bioidentical Rhythmic is number one. That's the best. Static is okay. It's good. And then the most important part of all of this is communication. You got to, because you want to feel good. Don't hesitate. For me, don't hesitate to call. Don't hesitate to text or call. Ever. There's no bad question. That's just an attitude I've had ever since I was little.
And I know you mean that, because I have called you for all kinds of stuff, and any time of the day, and you will, if you're available, you will pick up the phone and you will talk to me.
Yeah, just keep calling. It's okay.
So don't give up with your hormone replacement therapy, and don't give up trying to call Dr. Mathis. Well, this was really great, Dr. Mathis. Like I said, I know how
Good.
many women have been helped by your videos and by you in general. I'm so grateful for you, and so are many of my viewers. So thank you so much for doing this.
You're welcome.
Is there anything you would like to add?
I don't think so. I think we've covered a lot of ground here.
So thank you so much for being here, Dr. Bob. Goodbye.